Well, welcome, everyone. I'm Brian Spielmann, founder and CEO of Academy of Therapy Wisdom. And today's webinar is with Andrew Tatarsky and called Stop Saying I Don't Work with Addiction. And we really chose this title deliberately because I think it names something most of us have felt but rarely say out loud. And for probably many of you, some point in your career, you probably had a moment where a client started talking about their drinking, their cannabis use, their relationship to food or sex or gambling, and something tightened in you. And maybe you thought, this isn't my area. I should refer out. I'm not trained for this. And it just brings back like 4 years ago, Ace and I were filming Sarah Burgamy on gender issues. And at that time, anything with gender, sexual orientation, most therapists would farm out to a specialist. And Sarah's big message was, no, you don't do that. And here's the thing, the responsibility isn't your fault. Most of us were trained explicitly or maybe implicitly that addiction is a specialty, that you need separate credentials, separate settings, separate models, and that if you're not an addiction therapist, you shouldn't touch it. And that's when we met Andrew Tatarsky, who spent 40 years dismantling that assumption. Is that right, Andrew? 40? I'm making you like older maybe than you are. Andrew is the creator.
You're right. You're right.
Is it 40?
Over 40.
Over 40. He's really 120 years old, but he's got really good skincare. Andrew is the creator of Integrative Harm Reduction Psychotherapy, a model that brings together relational psychoanalysis, CBT, mindfulness within a harm reduction framework. His book, Harm Reduction Psychotherapy, has been translated into Polish, Spanish, Russian. He's trained clinicians and organizations in over 20 countries. And I got to spend a week with Andrew in Boulder when we were filming him. And what's compelling about Andrew isn't just his credential, it's his stance. He believes that addiction is not a disease to be treated in isolation. It's a meaningful response to suffering, survival strategy. And we understand this. We realize if you work with trauma, you're already working with addiction. You might just not have that framework to see it. So today, Andrew's going to challenge the dominant narrative that kept so many therapists feeling unprepared or avoidant, and he'll introduce a radically different, rehumanized paradigm. And one doesn't require absence, doesn't require specialized settings, and doesn't require you to become someone you're not. And I think he's also, we're working on a summit in the summer, and I think he's a model of a therapist that really has a global view of the humanity, public policy, just a really broad spectrum of looking at this field of addiction, and not just on the couch, which is really important, but how society looks at it. So welcome, Andrew.
Thank you.
I hope you're warm in New York, because my daughter's been complaining how cold it is there.
Well, it's been really, really cold. Last week I felt like I was in Minneapolis for a number of reasons, partly because my heart was in Minneapolis, but also because it was very chilly in New York. This week it's sort of warming up a little bit. But
so glad you're here.
Thank you so much for that lovely introduction. Actually, Brian gave some of the introductory remarks that I want to make before I get into my slides. But I want to thank everyone for joining us. And we have a lot of people joining us today from all over the world. So that's very, very exciting. I think what I want to share today, I hope will ultimately help folks psychotherapists feel more comfortable and more inspired and more curious about and open to working with people that struggle with addictive and compulsive issues. And I want to go through a lot of what Brian kind of summarized just to sort of make the case. Just briefly about how I got here. I am a psychotherapist, a psychologist, and a psychoanalyst, and I've been working with people that struggle with addiction for over 40 years, and their families and partners. And I actually began in the field for the first period of my career, working in the only way we could, which was this traditional disease model, abstinence-only approach. And I ran a few programs as clinical director, And I think we did help some people, but ultimately I came to question, and grapple with this very disturbing question of why was the field really failing to help the overwhelming majority of people that come to specialty addiction treatment. And unfortunately, that is still, all of these years later, true. And I came to believe, as Brian said, that the dominant model, the dominant narrative about addiction, or understanding addiction as a disease that requires specialists to treat it, generally in abstinence-only programs, is basically wrong. And that a corollary of that dominant narrative is that addiction cannot be treated in psychotherapy. And so as a result of that, I think many, if not most, well-trained psychotherapists have been taught explicitly and implicitly that they can't treat addiction. There's been very little training in clinical training programs on addiction. And so many folks who I think ultimately have most of the knowledge and skills that are required to work with these issues believe they can't. And when these folks walk into their offices, the tendency is to think, I can't work with this person. I need to refer them out. So essentially, just at the point when a person is asking for help, maybe even already engaged in therapy, the therapist feels, ill-equipped, and there's a missed opportunity to move forward with these clients. So the idea that I'd like to ask you to set aside or to consider for a moment critically is that one needs to be an addiction specialist to treat addiction. And I am not wanting to turn you into an addiction specialist. I'd like you to consider that you psychotherapists already have most of the knowledge and skills that you need, and you need a framework for supporting you in thinking about how to adapt what you already know and do to this huge, undertreated group of people. And I will share a few statistics about that are just, dramatic. So by the end of this brief webinar, I hope that you will feel curious and inspired to consider, changing the way that you practice or expanding the way that you practice. And you'll understand why we're asking you to stop saying, I don't treat addiction. Toward the end of the webinar, I will also introduce my approach, which is integrative harm reduction psychotherapy, that I really see as a framework for supporting psychotherapists in using their knowledge and skills more effectively with addiction and compulsion. I also think that integrative harm reduction psychotherapy can be brought into addiction treatment settings and really inform, bring a integrative therapeutic framework into addiction settings as well. So having said that, I want to go to my slides. So this is what we'd like, to have you consider over the course of today. And this is the core question, right? A really troubling question. Why have our helping professions done such a poor job of helping people who struggle with addiction? And I think it's not because addiction treatment professionals don't care or are not hardworking and dedicated. I think that most of them are. It's just that they've been hamstrung by wrong ideas and assumptions. Why do we need this paradigm shift? And in fact, this is really what I think we're in the midst of. There's been this dominant paradigm of addiction as disease and the implications of that. And we really need to shift the paradigm. That paradigm has kind of, I think, blinded or hamstrung or limited many otherwise great clinicians. This is the scope of the problem, which to me is just mind-blowing. This is data from a national survey on drug use and health that SAMHSA does every year. In 2023, there were 105 deaths from drug overdose and drug poisoning, which is increasingly a problem with the illicit drug supply. Over 1 million people have died in the past 20 years. In 2024, which is the most recent year that we have provisional data for, about 80,000 deaths. So there's been a decrease. But we think that that's largely due to harm reduction efforts, such as the distribution of Narcan. But that still amounts to 220 people dying a day. In 2022, 22 teens died of overdose each week. So these are really frightening and troubling numbers. And it's not just a marginal problem. I think that this is a problem that it's one of the greatest problems that people in the United States struggle with. 48.5 million people with substance use disorder, that is, significant negative consequences. That's a huge number. But even more striking than that is that there are estimates that around 100 million people struggle with problematic substance use that doesn't meet substance use disorder criteria. That's close to 150 people in the United States. And when you add in other addictive or compulsive problems, such as eating, gambling, out of control sexual behavior, gaming, shopping, it's another 100 million. So we're talking about most adults in the United States. And, what this, I think brings to my mind is the question of, is addiction an us-them problem, or is addictive and compulsive behavior, a human problem that really affects all of us to some extent? And I think one of the dominant clinical implications is that these people are coming into every clinician's office. Or many of them are not going to specialty addiction treatment because it doesn't match their needs or where they are. And so let's talk a little bit about the limitations of traditional treatment. Only about 10% of the people with substance use disorder actually receive specialty addiction treatment. And when they ask people who need and want treatment why they didn't get it, the number one reason is because they don't want to stop completely. Then following that, stigma and a lack of treatment, availability of treatment are secondary problems or limitations. Now, if 10% of the people with substance use disorder actually go to treatment, less than half of them actually complete it. So, we're down to less than 5% of the substance use disorder, and many who complete don't maintain abstinence. So I think this really reflects the limitations of the model. Why aren't most people going? Why aren't most people completing? And why aren't most people maintaining their gains? So I'd suggest that it's the dominant model that is the problem, not the people who are providing services. And this is the dominant paradigm. We've been taught to think about addiction as a disease treated by specialists, and abstinence is the only acceptable goal. And often people need to commit to abstinence to get into, specialty treatment. So if they're not ready to stop or interested in stopping, and most treatment requires a commitment to stopping, there's a mismatch there, right? And this idea has also given rise to this split between the addiction treatment world and the mental health world. And as I said, mental health professionals, by and large, have been taught that you can't treat addiction in a psychotherapy practice. So what's the consequence? Minimal training for therapists. Therapists just tend to believe this is not my lane. I think there are these reflexive referrals, on many of the psychotherapy or, mental health listservs that I'm on. I frequently see questions, does anybody know of a good rehab? Anybody know of a good rehab? And, with minimal clinical information about what's going on with that patient, there's just a lot of therapists think, we need to refer out. And I think that these are really missed therapeutic opportunities. A client comes in, wants help, is motivated, begins to talk about substances, and then after having a good initial experience with the therapist, is met with the statement, I can't help you, I need to refer you. And I think that often this can contribute to what I have come to call drug treatment trauma or addiction treatment trauma. That is, a person is often prejudged, not seen, and then sent away. And, that can really be terribly, difficult for folks, and it can repeat earlier traumatic rejections and assumptions. So I wonder if this is a familiar clinical moment that many psychotherapists have experienced. You're working with a client, things seem to be going well, moving in a good direction, you've got a good alliance, and then the person says something like, I think I tend to drink to unwind, or maybe I'm a little concerned about my drinking, or I smoke weed to shut my brain off. When I get really overwhelmed, sometimes I binge. And what does it bring up for us? There's a pause. As Brian said, is there like a tightening in the stomach? Ugh, what do I do? I haven't been trained. I've been taught maybe I can't help these folks. Do I follow this? Is this mine to treat? Should I open a door that I don't know how to walk through? Do I have to be confrontational? And I think that's another presumption about working with people with addictive issues, is that they need something else. They need a more confrontational approach. And most therapists don't work that way. So this is a challenge. And I think what I've heard from many, many clients in my practice is they were in therapy. They brought up substance use. The therapist didn't pick up on it, didn't express curiosity, didn't really ask about it, never brought it up again. And the message to the client was, I guess I can't talk about that here. So what if we consider what I think is a more experience near way of thinking about addictive and compulsive behaviors, as meaningful responses to suffering. They can serve vital functions in response to suffering and multiple functions and meanings simultaneously. So let's consider self-medication, which I think is an idea that is, out in the field and many people understand, turning to a substance or activity to manage pain of one sort or another. Alcohol for anxiety. It's not a one-to-one correlation, but there's a connection between the behavior and suffering. Cocaine for depression, et cetera, et cetera. Affect regulation. Very often, people struggle with overwhelming challenges around feeling states, feeling too much, feeling too little, which is often related to trauma. And there's a very high correlation between trauma and addiction, whether it's developmental trauma, big T trauma, or the trauma of being a person who struggles with drugs or other stigmatized activities. So managing the symptoms of trauma, the consequences of trauma, may be a function that the substance or behavior serves. Self-regulation and coping. So, rather than thinking of these behaviors as pathological, they may actually be turned to manage. I had a patient in the mid 80s who was an early HIV patient. And at that time, HIV was a death sentence. And he told me in a treatment program I worked in that he was continuing to use cocaine because he was so terrified, anxious and depressed that he had difficulty getting out of bed in the morning and getting to work until he took a bump of coke and it enabled to get up. That was one of the early experiences that put me in a quandary and challenged me to begin rethinking the addiction as disease model, because here this was actually helping him function and cope. A survival strategy, folks that are homeless or in very, very difficult life circumstances may find substances to be vital to their survival in one way or another. Then substances can become relational substitutes. Lisa Director and Debbie Rothschild have written beautifully about how these behaviors not only have a kind of a self-medicating or self-soothing, self-coping kind of function, but also have relational meaning in relation to early relational conflicts that then get carried into later relationships. A very simple way basic way to think about it is, why would one turn to a substance rather than a person for support? Because of some early conflicts, relational conflicts. And I see in the slide, it's an expression of, that's interesting, fill in the blank. But I think what I meant to put there was an expression of split off, disowned, dissociated, unwanted parts of the self, feelings and needs that were not acceptable or integratable in early relationships, may find expression in the behavior. Think about the screw you binge. There's a feeling that gets expressed that may be out of awareness. So addiction has meaning. People may turn to substances both to manage intense shame and guilt, and also to punish themselves because of intense shame and guilt. I alluded to these internal conflicts and splits where a part may be turning to the substance for one reason, while another part may really not want to be using, may want to be connected to others. Rebellion against the inner critic. Many of these folks have incredible, harsh inner critics, superegos, pounding away with self-attack. And one way to deal with that is to use a substance to put the critic to sleep. The problem is the next day, the critic can return with a vengeance. So this can contribute to, using and not using and using. I talked about expressing these split off parts of the self. Loneliness, desperate attempts at connection can be sought through using substances. And maybe in relation to that superego or, internalized dominating parts, one might use as a way to rebel. And when others make demands, there's a kind of a tendency to submit and then rebel. So the point is that, if we begin thinking about meaning and function, we can consider, the relationship between these behaviors and all sorts of things that psychotherapists are already very proficient at dealing with. We just need to think about the connection. Very quickly, Allison is a woman that really illustrates this kind of relational aspect. She has a long history of binging on alcohol. I'm currently working with Allison. Her mother thought that conquering hunger and other needs was one's greatest accomplishment. So that was kind of what she passed on to Allison. Don't give in to your hunger. Don't give in to your vulnerability or your fears. And she also grew up with a physically abusive older brother. When she asked for help, her mother said, "Why did you provoke him?" So what was the message to her from both the mom's relationship to needs and what, she said she was blamed for reaching out for help? Well, she stopped turning to others for help. She stopped expressing her needs and even stopped feeling her feelings. And so now, whenever she's in a situation that she doesn't want to be in, or she feels pressured into being, very often she's vulnerable to over drinking. And, the work has been, for now a couple of years, we've gotten to the point where, we're both kind of becoming aware that when a feeling threatens to come up, she has a tendency to disconnect, and then she has a tendency to overdrink. And this was really captured in this phrase she used in a session recently when she realized, when I fake, I drink. So she's beginning to recognize what's behind the faking, being able to integrate feelings, and we're talking about how she can bring them into her life. But then, the things that we turn to that actually help us are rewarding in some way. Also, then can become coping mechanisms that can become deeply ingrained habits, or what we might think of as overlearned habits. Stimulus, response, reinforcement. We do that with our dogs. We also do that with ourselves. If I'm anxious, I have a drink, I feel better. That can reinforce the urge to have a drink. It's not just the behavior, it's the urge, it's the craving. When I feel anxious, I want a drink. And when I drink, it reinforces that. And that's repeated thousands of times, possibly. That becomes deeply encoded in neural networks through repetition, neuropsychologist Mark Lewis tells us. And so this has led me to this idea that the urge to engage in these behaviors, we can think of as an axis of change, right? If we could stop the action with the urge, with mindfulness, with breath, with curiosity, put a little pause around it, it opens up all sorts of possibilities for promoting positive change. And finally, biological factors. People say, well, of course there's biology involved, and of course there is. But I would suggest that biology doesn't drive it. Biology may be another factor. So we're talking about psychological and biological and relational factors that are all interacting. We believe that the research suggests genetics increase the possibility or the vulnerability to engage in problematic substance use. But there's not a cause, right? There are other cofactors that come into play. With chronic substance use or even other, addictive behaviors, we will see neurochemical depletions, neuron receptor sensitivity shifts. There may be tolerance and withdrawal. But what I would like to suggest is that the biological factors become more of an additional motivational piece over time. So it's not what initiates, right? But it may over time, and particularly with some substances that have very painful withdrawals, like opioids and alcohol, can become a major factor that continues to promote the behaviors. So therapeutic implications. Well, the addictive relationship to a behavior or a substance is going to express and disguise split off, dissociated parts of the self, or maybe linked to, these other co-occurring emotional and relational factors. And to that extent, the behavior and the urge to engage in the behavior, we might think of as entry points for an exploration, a rediscovery and integration of those parts of the self. And therefore, and this I think is the dominant theoretical rationale for why we need a harm reduction approach that welcomes clients into therapy with their behaviors, rather than saying you need to commit to stopping the behavior before we can help you. And this is something that all therapists do with anxiety, with other emotional and relational challenges. We don't ask patients to commit to stopping their depression or their panic attacks. Of course, a part of them wants to give up their depression and panic attacks, but there may be another part that's invested for various reasons or conditioned for various reasons. So very briefly, I want to talk about two clients, Peter and Sarah, I've written about in a Psychotherapy Networker article that you can find online, The Challenge of Harm Reduction. Peter was a man that came in a number of years ago, and I'm still working with him. And in the first session, he told me he was smoking crystal meth, and he was having a love affair with crystal meth and sex. And he described how he would go on these multiple day binges. He was a successful attorney, and at this point, he was still keeping his practice together and his marriage, but he was beginning to suffer. And while he said that he was in this love affair with it, he also said he knew that he was putting everything that was of value to him at risk. He would go into hotel rooms and apartments with strangers that he met online, knowing that he was taking great risks. And sometimes people would have psychotic episodes, would become violent, and he barely escaped, unscathed. But he was caught in this dilemma, and he wasn't anywhere near ready to stop. Sarah was a woman who had used alcohol and cannabis for many, many years. And she described early on in our work together how it really helped her relax and unwind. And, there was this kind of la belle indifference, like it was just a nice thing in her life, except that sometimes when she woke up hungover, she could have a grand mal seizure, which could kill her. And she had been in treatment with a neurologist for 7 years who had been kind of hammering away at her to go to AA and stop. And she was not willing to do that. And ultimately, he referred her to the harm reduction therapist. And she came and she was very motivated. So here we have two people. Oh, and by the way, she was also caught in a kind of dilemma where, although she said she just really enjoyed it and it was a very wonderful thing in her life, she was very aware that she was putting her life at risk. And yet she, like Peter, was caught in this dilemma and was not ready to stop or to cut back, although she wanted to. So what do we learn from those clients? And how many of them walk into your offices? What would you have done if they walked into your office? Would you refer out? That would be, I think, kind of a knee-jerk reaction. Would you say, I'd love to talk with you and work with you, but you need to commit to stopping? I've heard some clients say they had that experience with therapists that they felt, profoundly misunderstood by and possibly traumatized. Or would you stay engaged? Would you, and how do you go about making that decision? In both of these cases, I felt inspired to work with them because they were both very motivated, very self-reflective, very much wanting to work on finding a way out of this difficult dilemma. And I felt deep, compassion and empathy for their struggles. And by the way, they both did incredibly well, I should say. Peter, at this point, has not used crystal meth in about 2.5 years. Sarah actually wound up very, very successfully moderating her substance use, and she's now running a nonprofit health-related organization. In both cases, there was a lot of trauma and unresolved grief that we needed to work through in order to for them to get to the point where they could make those important behavioral changes. So now let's shift to what we gain when we consider harm reduction principles as a therapeutic frame. Most people know harm reduction through its public health applications, clean syringes, Narcan, condom distribution, safer using practices, which, are the bottom line. If we can't help people stay alive and healthy and safe, we can't help them, move forward in any way in their lives. But let's help people stay alive and safe, and then bring, sophisticated psychotherapy to them to support them in, pursuing the kind of quantum changes that they want. I think harm reduction centers dignity. That is, we see folks as, worthy of the same kind of care, respect, support that everyone else deserves, despite or regardless of their substance use status or, the behaviors that they're involved in. Alan Marlatt talked about the philosophy that is expressed in action in harm reduction practice as compassionate pragmatism. Compassion is what drives our desire, or is our desire, to reduce suffering and promote positive change and well-being. But the pragmatic part is that we need to be constantly evaluating what we're doing in terms of how well it's working. And I think that's a great question for us therapists to be asking in our therapies. How are we doing? And to ask our clients, how are we doing? So that we're constantly open to, working collaboratively to create a therapy together that is going to be most effective for this person at this point in their process. I think it's also a great harm reduction question for folks who are engaging in risky behavior. How is this working for me? We see that the client is an expert in their experience. We don't have the expertise. We have our expertise as helpers, as therapists, but they have their expertise in themselves. And we want to invite them to kind of claim their expertise and bring it into a collaborative therapy team. That's an idea that Pat Denning came up with. Then we want to embrace any positive change, small steps or quantum leaps. But that's, I think, another really shift in the paradigm from, abstinence, the ultimate goal, maybe for some, or moderation, is an ultimate goal, but that's not generally where people begin. People begin where they are. So we meet them where they are, and we support them in beginning to goal set in a positive direction. So we can invite people in all stages of change, not just preparation or people ready to take action. And we can work with people around all positive change goals. So this is going to really lower the threshold so that we can meet people wherever they are ready to step into our support. And I think the dominant attitudes that I want to bring to my clients are curiosity. I just met these folks. I'm not going to presume to know about the nature of their complex relationships to substances. Empathy. I want to really try to get a sense of who they are, what they're struggling with, kind of where they are. Respect and empowerment, collaboration. And I think that's another key shift in a harm reduction way of working from the old sort of more authoritarian, prescriptive, sort of we know what's best for you, to, working in this collaborative way, supporting people and getting in the driver's seat of their relationships to these behaviors. So now I want to, sort of briefly summarize the integrative harm reduction psychotherapy approach. Essentially, given that these behaviors have taken on multiple meanings and functions, we need a focus that's on clarifying personal, relational, and social meanings. But because behaviors are also problematic, risky, maybe highly risky, we also need to have a cognitive behavioral focus on promoting positive behavioral change, identifying what's problematic, and kind of goal setting around positive change. I think mindfulness-based techniques are really very powerful ways of supporting these other focuses of the therapy. And it all happens within a harm reduction frame. I've got about 5 minutes left, I think, and I'm going to now just quickly summarize the 9 therapeutic tasks of harm reduction. This is really how I've mapped the therapeutic process. I think there are 9 basic focuses that we want to be working on with clients. And while these 9 tasks kind of build on one another, it's not really, I don't see it as a protocol, as steps, stages. At any one point, we may be focusing on therapeutic alliance or focusing on our relationship or, enhancing self-regulation, or the urge emerges, and then we can really focus in on the urge as the axis of change. Assessment as treatment is an ongoing activity that we do as we move from behavior to clarifying the context of these behaviors, the meanings, the functions. That's going to really broaden the therapy from that behavior to the other key issues that people grapple with. This I see as like a compass, like it's a way of orienting in any moment. Where are we? What are we working on? Embracing ambivalence, I think, is such an important focus. In the old way of working, we just want to talk with the part of the person that wants to change. The part of the person that is invested in the behavior has been left out. I think in this framework of meaning and function, we want to invite the part, or we need to invite the part that is invested in these behaviors in to speak, to understand what that relationship is about. So we can then sort of support a constructive dialogue between these parts about positive change goals. If we can help folks develop healthier ways of managing anxiety, that in turn will support, the part of the person that wants to cut back or stop. And, so we're moving from task to task based on what is that client bringing in any particular moment, what's alive in the room, the relationship, etc. So just a few words about the tasks, and then I'm going to stop and we're going to kind of dialogue a bit with Brian and then open it up for questions from everyone. So the first task, obviously, is creating safety and alliance. And I think a harm reduction frame really facilitates that by meeting people where they are. We invite them to share with us, what brings them. We meet them with this empathic listening stance and checking in with therapeutic humility. When we can reflect back to the client that in such a way that they feel heard, we know that we're in alliance. But this way of working with people also, I think, can really enhance that corrective emotional experience, giving people an experience who have, felt punished or stigmatized or rejected because of their behaviors or because of the issues that get expressed in those behaviors. And this harm reduction frame invites people in, meeting them with compassion and respect. And I think that new relational experience is inherently healing for folks. Then in terms of self-regulation, which Henry Crystal, Ed Cansey, and others have suggested is really at the heart of addiction, that empathic attunement, I think, co-regulates and helps people regulate themselves. But also we can bring and teach skills of mindfulness, breathing techniques, grounding. Urge surfing is what I was talking about before, bringing mindfulness and breath to the urge to create that pause And then assessment as treatment is really about supporting people in getting the sequences of thoughts, of feelings, of circumstances, et cetera, that kind of the problematic behaviors are embedded in. And once we can help people identify urges, become curious about them, we can start a dialogue, kind of what I think of as unwrapping the urge, discovering what's living in there. I talked about embracing ambivalence, where we're inviting both sides to speak, shifting from a battle between the parts to supporting a constructive dialogue. I think this sitting with ambivalence is also the experience of being integrated. And being integrated in relation to the therapist is a new way of being, more fully present, which we can support people in bringing into their lives. The goal setting is any positive change, new solutions, new, more effective solutions, solutions and alternatives to the problematic behavior that are more in sync with people's values. And let's bring an experimental attitude to goals. Not pass fail, but what can we learn? And finally, when we've got some good goals, we can start talking with people about strategic, comprehensive, personalized planning for how people will work toward those goals. One idea that I love is, the ideal use plan as a framework. If you could imagine and design a way of having a plan for having these behaviors in your life that would maximize benefits, minimize risks, what would that look like? And that we can then work together to sort of discover, create, fine-tune that plan. And finally, countertransference management. If we're working with folks that are engaging in really risky, scary, often behaviors, it's going to kick up all sorts of feelings in us, fear, sadness, et cetera, kick up our own personal stuff. So if we can manage it and contain it, and kind of stay grounded and present with what's coming up for us, we may be able to use that as an important source of information about what's happening with the client and between us. And I think, obviously, there's no one way to manage countertransference. Each of us has to find our own techniques, our own tools. But that's got to be a central focus from the beginning of our work with people. So I think this approach is going to inherently strengthen the alliance, and that is going to help us feel less anxious as therapists and more confident. We've got a partner in the therapy. Fewer of us will feel like we need to refer people out. I think it reduces our burnout. And finally, when we stop saying, I don't treat addiction, I think we restore dignity to the clients and to ourselves as therapists. And I hope I've inspired some curiosity, some openness to really consider how you might bring some of these ideas and practices into your psychotherapy practice. Thank you so much.
Thank you, Andrew. I just so appreciate your humanity and that you've just taken this on as your personal mission. It's so clear. And I think for most clinicians on the call who are not addiction counselors, hopefully something shifted further. You obviously were interested in this call, but addiction wasn't really your territory, your forte. And hopefully sitting with Andrew, you realize you've been sitting on caseloads all along, just maybe wearing a different outfit. Maybe it's a client who drinks to manage anxiety, takes cannabis before bed, ones who can't stop scrolling, or the relationship to food becomes a way to disappear. So you've already, for most of us, been working with addictions. And I think what Andrew's point is, you just didn't have permission to call it that or a frame that makes sense. And maybe another part of you is thinking, okay, I get this now, but how do I actually do it? How do I hold this in the room without feeling like I'm in over my head? And that gap between seeing the problem clearly and knowing how to work with it skillfully again and again is exactly what Andrew's full training is designed to bring and to bridge. So, as Andrew pointed out, most therapists are already seeing clients with addiction and compulsion, but because you've been told for school and years that you're not qualified, and Andrew had that slide, you either avoid the topic, refer it out prematurely, or work it with in a way that's inadvertently increases shame. And the dominant models aren't working. Disease-based, abstinence-only frameworks works for some people, but they fail for the majority. And that's why Andrew's training exists. Should we put it on screen? Oh, let me just say, this is not an abstinence-only model. It's not a certification that turns you into addiction specialists, or to abandon your current orientation. It's a comprehensive 7-module training with Andrew.
Can I make a couple of comments?
Please, Andrew.
I think one of the most important ideas to disarm or to take on is harm reduction is really about developing a therapy that engages people across the whole spectrum of positive change goals. That includes abstinence. I think this is a major misnomer that many people have. I often hear people say, is it abstinence or harm reduction? Harm reduction is about, respecting and affirming everyone's choice, even though I critique the disease model, even one's language. If disease is a valuable metaphor or idea that a client finds useful, I respect that. I'm not about, imposing. That's really one of the key things about this harm reduction stance. I don't want to impose my values or my ideas, my theories, my assumptions on the people I'm trying to be helpful with. So that's one. The other thing is I noticed in some of the responses in the chat, affirming. And I think this is something that I often hear from people and something that I felt when I was first introduced to harm reduction. That is, that it felt like something that we should be doing. I didn't have the language for it. I didn't have the model for it. And so when I was given the language and given the model, it was like, yes, that makes so much sense. And I think some of the folks out there are reflecting that they're feeling something like that as well.
Okay, I'm going to show the screen. Here's the course. We wrote about this one in the emails. Was it centering dignity? That's like Andrew's essence. It would be another subtitle for integrative therapy for addiction and compulsion that I think Andrew's pointing to. So should we go through the the modules, starting with module 1, which we start in 1 week, February 12th. And everything's pre-recorded, everything's recorded and transcribed for you. You want to start where we're at here?
Yeah, so in this overview of the training, it's really foundations, and we go into these dominant narratives around addiction. I think we've talked about the disease model, but I think it's also important for all of us to recognize, we grow up in a culture that is stigmatizing, has these old ideas about addiction as moral weakness, the narrative of, drug addicts as criminals. And while rationally many of us may know that that's not accurate, it lives inside of all of us. And so it's so important to recognize and think about these different narratives and how they have really informed or limited our ability to be helpful. That's the cultural myths and stigma. I think, then this is an introduction to harm reduction and how it applies to psychotherapy. And we talk more in more depth about the things that I touched on, meaning, function, trauma, habit, and how they all kind of intertwine in addictive behaviors. What I call the psychobiosocial model. I didn't mention that before, but if we think about psyche, bio, the body, and our relational and social context really as being in this constant dynamic interaction, we really need to be looking at how all of these different elements of human experience come into play. in contributing to these behaviors.
Module 2, a quick review, harm reduction from public health to psychotherapy.
Yep. So here's where we really talk about in more depth harm reduction definitions, the history of harm reduction, which is really fascinating, really emerged as an activist-based movement, really, from marginalized, underserved communities who were dying of HIV and AIDS in the 80s. And nobody was really, the dominant culture wasn't really reaching out to help. So that's really where it emerged. Unfortunately, it took that level of crisis to begin to shift the culture from supporting only stopping the behavior to supporting people who are engaging in these behaviors to reduce the harm, and I think that, how that then relates to psychotherapy, we talked about briefly together, but we'll go into the principles in more depth in this module.
And let everybody know, we locked Andrew in the recording studio for 3-4 days. So in addition to each module, you'll have recordings broken up in 10-15-minute segments to go even deeper so that our live training calls can be a lot more Q&A, demos, and take the teachings even further. Module 3, why harm reduction is essential to effective helping, rationale and theory.
Yeah, so this really goes into what I call the multiple meanings model and the psychobiosocial model in a lot more depth. I think we will get to, I talk about trauma, which many therapists know a lot about, but how trauma and the consequences of trauma can render people vulnerable to turning to these behaviors in attempts to manage overwhelming feeling states.
And then module 4, and we have a rhythm every 2 weeks, so you really have time to listen to the pre-recording and then digest the live calls with Andrew.
Mm-hmm. So this is really about that first, what I think of as the first therapeutic task, creating a safe relational container. We talk about a little bit about, why is the therapeutic alliance the most important predictor of positive outcomes? How do we skillfully respond, to situations that can trigger our countertransference when a person comes into the room intoxicated, when, we make plans with people and they don't follow through, when we've got a safety plan and they wind up engaging in highly risky behavior, both how do we respond internally to manage, the impact that it has on us, but how do we respond clinically? And I'll just say at this point that I think if we consider that these behaviors are meaningful and possibly meaningful communications, I think an old practice that many therapists just think they have to do is if the patient comes in intoxicated, you have to sort of send them home. I think that can be one of the worst things to do because, inviting people who are intoxicated to kind of stay in the session and really try to kind of both understand what's going on for them, help them understand, but also create a kind of an experience for people that, we're not just talking about accepting them where they are, we're actually embodying that. And that's, I think, the kind of thing that can be part of that new relational experience or corrective emotional experience that can be so healing.
I had such an emotional response to that, Andrew, because I had a relative who had surgery, got really addicted to Oxycontin, and then went for a refill, and they said she had other drugs in her system, wouldn't give it to her. She bought some fentanyl on the street, and her mom, my aunt, woke up like 1 in the afternoon, and she was dead.
Oh my God.
Like she had a medical triggered situation for her addiction, and they wouldn't refill it. So
I'm just noticing greetings from Ray Perez, one of Edith Springer's children. Oh boy. Hey, Ray. Edith was one of the first people that I met when I was introduced to the harm reduction world in 1996. She was one of my mentors. Um, we call Edith the godmother of harm reduction psychotherapy. Uh,
Mm.
she ran a program called NIPAC, New York Peer AIDS Educators, uh, working with mostly homeless youth on the lower west side of Manhattan. She is an amazing, amazing woman who, thank you for bringing her into the room. And
Okay, Module 5, self-regulation and assessment.
yeah. So again, if people are turning to these behaviors to try to manage overwhelming emotional states that are disabling, to ask somebody to give up that um, coping strategy or that strategy that may be helping them stay sane might even feel like a death threat. I mean, I've thought about it as that dramatic. In order to stay on this job, in order to stay in this therapy, in order to stay in treatment, I mean, this is one of the early things that, was so disturbing to me that sort of forced me to begin to rethink those early assumptions is the idea that we kick people out of drug treatment for using drugs. And we just take it for granted that that's what we have to do, as if that somehow the threat of that um, is going to be motivating. And in fact, I think the threat of that can set people up to fail. But so we go into understanding, affect regulation, emotion regulation, self-regulation, and a variety of techniques and strategies that I get to demonstrate. So I'll be teaching a bunch of these techniques that you'll have an opportunity to learn.
And the last module 6, action planning for positive change.
Yeah.
Oh, that's not our last one. I'm sorry. Wow, we're giving a lot. We have another module after this.
So, we're helping people bring all of the parts of themselves in, their ambivalence about change. Then we're helping people really unwrap or kind of get clearer about what are the motivations and the values, that are being expressed in those parts. And then that can really open up this very valuable constructive dialogue about how the parts that want to engage in these behaviors can really make some changes that will be in accordance with the parts that want to cut back or stop. And then that in turn leads to a meaningful discussion about, a kind of strategic plan. We might think, for those of you that are familiar with the stages of change model, trans-theoretical model, now we're talking about the preparation phase, which, by the way, is another pre-action stage that requires a harm reduction approach. Because people may know that they want to cut back, they want to use more safely, they want to stop. But how do they go about doing that? Inpatient, outpatient. Can they stay in this therapy with us? Do they involve other folks as a support system? What are the strategies, the really, urge surfing, avoidance strategies, all sorts of behavioral strategies that will kind of support the implementation of that positive change plan. Debbie Rothschild calls this behavioral coaching. And I think a lot of therapists are kind of reluctant to get into the nitty gritty, but I think that that's really important. And just to go back to what I said at the beginning, I think in the psychotherapy world, there's been this unfortunate split between approaches to psychotherapy that really focus on meaning and function underlying issues. And some people think that's all you need to do. I think we need to do that to the extent that it, is in accordance with where a patient is, a client is. But I also think when we're talking about really problematic behaviors, we need a behavioral and cognitive focus too, active, strategic focus. So here we're talking about teaching skills, looking at, behavior, and what, if we can identify a moment when there's a context or a behavior that contributes to harm, that can then point to small behavioral changes that people can experiment with that can reduce harm. So
I'm going to jump in, Andrew, so we stay on time. And then module 7, and then we'll go into some of the bonuses, the inner works, countertransference, and therapist self-awareness. And then you can tell Andrew's got a lot to say. He's got so much depth of information. And I want to go over, we have some really great bonus interviews that Andrew did. You'll get an excerpt of his book, Pioneers of Recovery Treatment, a podcast interview, a case problem drinking second to depression. And then our interviews, we have Maya Solovitz, a great New York Times writer.
Yeah, I consider Maya to be our harm reduction journalist. She writes for Time, for the New York Times, for many different publications. She's written some amazing books, Undoing Drugs, The Unbroken Brain. So we had a wonderful conversation.
We have Sam Rivera.
Yeah, Sam Rivera is the executive director of the country's first overdose prevention center or supervised consumption sites in Manhattan and the Bronx. In my conversation with Sam, I learned that, supervised consumption sites are very controversial. People often think they're, quote, enabling. At the end of this conversation, you will be an intense supporter of the work that is done in these settings. He told me the first supervised consumption site was opened in 1986, 40 years ago, in Switzerland. They have proliferated around Europe, and now a few of them are here. And get this, he told me that in these 40 years, with millions of people injecting or consuming substances in these safe, supervised settings, there has not been one death. So let's think back to the statistic that I shared. About 1 million people in our country have died over the last 20 years. Sam said, this is preventable. So if we become harm reduction therapists, and we invite people into our offices who are using unsafely, and we can begin to support them in learning about safe practices, we can prevent, the third largest leading cause of death in the United States. So thank you, Sam. He's a wonderful spirit.
And a second about Pat Denning.
Pat Denning, she's a psychologist, and she's really one of the leading spokespeople for harm reduction psychotherapy from the West Coast. She is a founder of the Harm Reduction Therapy Center. She wrote 2 wonderful books, Practicing Harm Reduction Psychotherapy. So we get kind of the West Coast perspective from Pat.
So we've discounted the course to $497. Usually Andrew's 2-day courses are $1,000. After this training, you just won't understand harm reduction. You'll practice it. And 3 months long training, so that you can really incorporate this training and make it your own.
Well, don't we also will be doing live Q&A sessions.
Yeah, that's what we went through the modules and it had the dates. Yes, 90-minute live Q&A. I wrote some notes. Let me see anything else, and then we'll do Q&A.
Oh, West Coast harm reduction guru. Um,
So it's your invitation. If this teaching landed, something opened up, even a crack, invite you to be part of Andrew's program. You could just tell there's just something different. It's not always just the words, there's just some transformation that happens when you sit with somebody who is just so steep in an area of expertise, and has so many clinical years behind them. So thank you all for joining us today. We'll do Q&A. And just the fact that you showed up today, says something about you, that you're willing to challenge assumptions, including your own. And I think that's the kind of therapist we need today. So Andrew, I find your approach so helpful as calm my nervous system as I listen to you. The countertransference can take off sometimes. Can you please speak to any guidance that you have for me in couples therapy where one spouse is active addiction coming in?
yes. So, my approach, IHRP, was first really designed as an individual therapy. For 12 years, I founded and ran the Center for Optimal Living. We had a comprehensive therapy approach available at the center. And so we were able to really expand and work with couples and families. And I think this is really a very, very important kind of cutting edge of harm reduction therapy. And of course, I have worked with many couples over the years and families. And so I think that if we think relationally, as I alluded to, at the beginning, that is that there are not just individual dynamics that get played out in the relationship to these behaviors. There are relational dynamics. And those dynamics generally are going to be played out and expressed in current relationships. So to that extent, it seems to me that a relational context is one of the most powerful contexts for helping people get clear about the relational meaning. Why is a person using what goes on in their relationship or in their relationship to their partner that they're using when they're upset, when they're overwhelmed, rather than turning to their partner. And so we can actually track these patterns, and how might the partner be also contributing, right, to the lying, the hiding, so there's a co-created process that happens, as if you're a couples therapist. And why do we traditionally say the person has to stop using before they can benefit from couples therapy? We don't say that about any other, powerful issue that an individual has. So, that's just one piece to it. And I think, there's just one other idea that, often in a couple's relationship, when substance use is an issue for one, or really a problematic behavior is an issue for one partner, they're often in a battle. And if we can sort of help them begin to kind of create a space to hear one another, the battle, like with ambivalence within the individual, can shift from a battle to a constructive conversation about how can the partner create safety and support for the person who's struggling, but also how can the person that's struggling with the substance or other addictive behavior support their partner in calming down, in feeling more hopeful, etc. So those are some ideas that I have about that.
And a follow-up question from Eva. And Sean, if you want to ask your question live, let us know. Otherwise, I'll read it. Eva asks, I'm working with a couple. The spouse is with SUD, is pursuing harm reduction with some success. The other spouse insists that nothing less than absence will help her rebuild hope and trust. How do you work with that?
Yeah, I mean, this is one of the biggest challenges, because I think that if a person is pursuing a harm reduction therapy, a harm reduction path of one sort or another, um, and has kind of begun to get educated and find that to be of some value, and the partners or the family who have been indoctrinated by the dominant culture have been told explicitly or implicitly, until your partner is ready to stop and commit to abstinence and go to rehab or go to AA or whatever it is, they're just kidding themselves. So I think that those folks are generally loving, caring, people who want to be supportive in the best way they know how, but they've internalized these ideas. So I think the challenge is, if we can't get them on board with the person who's pursuing the harm reduction approach, there's going to be inevitable conflict. And so what I often hope to do, strive to do, is to see if we can bring those people into the process, and going back to the idea of paradigm shift. If you've only got one paradigm, you've only got one lens that you can look through, that's how you see reality. So we've got to give people the new paradigm. They need to be educated. They need to kind of really see if this, the person who's using is using to self-medicate or using for some complex reasons. We have to address that before and while we're helping them address the behavior. So that would be, I would want to invite them in if the primary patient gives me permission, either separately or very often with the primary patient, so that we can try to get everybody on the same team. That would be my goal, so that everyone on the team feels like there's a treatment plan that they can buy into.
Thank you, Andrew. Sean asks, and I imagine other people have the same question: how do you maintain a non-judgmental and curious approach when a client is reporting extremely risky addictive involvement that arousing fears of liability, etc.? Obviously, cover your ass should not be the guiding paradigm for a therapeutic alliance, but can you share a bit about how you would have utilized person-centered principles to navigate situations where the risks are acute and the client is struggling to engage in constructive safety planning, harm reduction? And Are there situations where you draw a line?
Wonderful question. Thank you for asking it. That question should always come up. Ideally, these harm reduction principles really facilitate a very strong working therapeutic alliance. So when I'm working with a person and we're working together and we've been successful at creating a sense of safety, that sets the stage for being able to evaluate risk, right? So that we're actually talking continually about risk, about what's going on, about goal setting, about how it's going, about, say, episodes that are really more problematic or risky. So I have an ongoing sense that things are going in a positive direction. Sometimes, so I need to have that agreement that we can talk about the nuances and the details. If I don't have that level of buy-in, then I'm kind of flying in the dark. And then I begin to get very worried. So rather than, that becoming a reason to kick them out, or, I want to bring my concern, my worry, my experience into the room. And so that's how I do it in a compassionate, respectful way. I say, and this has happened, luckily, only a few times in my career, but where things seemed to be going along very well for a while, and then something shifted, and I started to feel anxious. And then I noticed we're not really talking about these risky behaviors. And I brought it into the room, that if, in a sense, I need to really know what, I need you to bring me into what's going on in order for me to feel, confident that this therapy is helpful or is helping you stay safe. And it becomes even more challenging over time when we come to care about our patients, our clients, right? Because then the possibility of them doing serious damage to themselves or others, or worse, increases the stakes for us. So I want to share my experience. I'm starting to feel like there's a disconnect. I don't really know what's going on. I'm starting to feel worried. In fact, sometimes I might say I woke up in the middle of the night, with a bolt thinking about you and wondering, why aren't we talking about this? So I want to bring it to you. Is something going on? Can you help me? And so it makes it a relational thing, and it makes it a collaborative thing rather than, kind of an edict from me. There have been a few cases where I've said, if something doesn't change, I don't think I can continue to support this therapy. Because remember, harm reduction is that we want to be working to reduce harm and in a positive direction. If I begin to feel like things are stalling and they're not kind of going in a good direction, then I feel an ethical responsibility to bring it in. In some cases, the few cases where that's happened, it's really led to a dramatic shift. Like there was some kind of rupture that we then got to talk about and repaired.
Thank you, Andrew. What I get from your lecture today and then I'm looking at the 35 questions, and it's like it's not about adding a specialty, you're expanding your capacity, and there's so much nuance and ethics to work with. It's kind of a more tricky than I think a lot of other therapy approaches. Marley asked, can you talk about working with patients who are involved in 12-step programs and how some of the basic assumptions are ethical to psychotherapy? How do you navigate this?
Well, I wonder if the person can identify what some of those basic assumptions are. Yeah, I would like to speak to my attitudes about 12-step programs. Yeah.
I think you slightly cover this. Do you conduct the sessions when patients show up high?
Yeah, I'd definitely like to get to that. But let me just say some things about 12-step programs. Back in the 80s, somebody from Harvard wrote an article saying 12-step programs are good medicine with some side effects. And she was a 12-step program supporter. So I think that many people engage with 12-step programs and find them to be life-affirming and life-saving. I think many people have no interest in engaging in 12-step programs. They just don't resonate for people. And I do think that for some vulnerable people, 12-step programs can be problematic. It's a huge community. It's not a professionally led program. In that community, there are a lot of wonderful, loving people, and there are some, narcissistic, controlling people that, fire their sponsees. So one way that I've thought about the relationship between 12-step programs and therapy is that if somebody's in a program, we as therapists can help them negotiate. There's a tenet, take what you need, leave the rest. So if people can take what's valuable to them and identify what's not, they can leave that and don't need to buy into it, even though I know many groups kind of have a pressure to kind of buy into the whole program. But so that's kind of how I think about it. And I have had many patients over the years who are in 12-step programs and in therapy with me, and there has been no conflict. Like some people can really use that program in a way that's very consistent with, deep psychotherapy.
Thanks, Andrew. Last question. What place, if any, does IHRP have with regard to the resurgence of use of psychedelic substances?
Oh, wonderful question.
I thought you'd like that one.
Well, so I think IHRP brings a therapeutic orientation to harm reduction settings, and it brings a harm reduction therapeutic orientation to addiction treatment settings, right? And a harm reduction orientation to therapeutic settings. But I also think, and this has been really affirmed by many people in the field, that IHRP is a perfect container for all aspects of psychedelic assisted therapy. Preparation, during the session, and integration afterwards, because it's inherently committed to not imposing on the client patient's process. And I think that that's how we want to support people in psychedelic assisted therapies. So I've been doing a lot of work with ibogaine, which I wish we had time to talk about, and the ibogaine treatment community. I've done a lot of work with ketamine assisted therapy and folks that are experimenting with psychedelic, psilocybin and other psychedelics. So I think there's a real synergy there. There's an article on psychedelic harm reduction and integration by Ingmar Gorman and a number of his colleagues that talks specifically about that. And they talk about how IHRP is one of the foundational approaches that they integrate into their work.
Any
Thank
final
you.
words? We're getting to the bottom of the hour.
Well, it seems like we had really a wonderful gathering of folks out there you were all asking some wonderful questions. And I noticed at the beginning that many people were really writing in with kind of very positive comments about resonating with the work. So I think it would be wonderful if you join the course. As I said, we after each of the recorded modules, a week later, there's going to be 90-minute session where we get to, do live Q&A and kind of process and work with all the material. So I'd love to have an opportunity to work with all of you in more depth.
And we'll do a meeting format, so it'll be very interactive. And as I said earlier, I think it's a subtlety in having discussion with Andrew for everyone to really understand different circumstances. And it's over several months, so you'll really have time to integrate this and really make it part of your protocol and your skill set.
Mm-hmm.
So thank you all. Thank you for giving us 90 minutes on today's Wednesday, halfway through the week. Thanks, everyone.
Yes.
Stay
Thank
safe
you.
for emceeing.
Be well.